Hello, can we take some seats, please? It might come as a surprise to many people in the room, but normally I am a good half hour late. So I'm very proud of myself, and you should all be very proud of me. And Paula Guerin, who I know in a personal capacity, would vouch for the fact that I'm always late to everything, and I'm trying my very hardest to keep us on time today. So I guess without further ado, we are now coming towards the business end of the day. And as I know many of you will have spotted, our own Minister for Health, Stephen Donnelly, has ripped himself away from the Department of Health and from his desk to be here with us, and I really do appreciate it. I know it means a lot for everybody in the room and for those that are online to know that we have the support of the government and the Minister for Health. Rare Disease Day is a big day for us. The Minister was at another event a few weeks ago, the launch actually of the I Am Number 17, which I have been meaning to talk about as well, the I Am Number 17 campaign. And I think it's a testament to the commitment that he has to the community, that not once but twice over the last couple of weeks he's been here. He was instrumental in establishing the steering group for the development of the new strategy, and I would like to thank him very much for his commitment to the community and welcome you onto the stage. Thank you.
Good afternoon, everyone. It's a great honour. It's a great pleasure to be here, and can I thank you for the invite. It's fantastic, I think, to have this conference informally as a symbol, really, of how important it is for our nation, for the island, and for government that we invest in and support those living with rare diseases and our healthcare workers who are working in this area. I want to recognise my Dáil colleague, Deputy Paudie O'Sullivan, is out there somewhere. I can tell you, after 4 years as the Minister for Health, the strongest advocate I have seen in the Oireachtas for rare diseases is Paudie O'Sullivan. He explained outside to somebody that what I meant. He was explaining to somebody outside that what I meant by that was, consistently annoying, but is absolutely not the case, I can assure you. Consistently advocating is what I would say. I don't think there's a Fianna Fáil parliamentary party meeting. We have them every Wednesday. I don't think we've gone through a single one in the last number of years without this coming up, and often led by Paudie and John Lahart as well. I really want to just acknowledge Rare Diseases Ireland and Northern Ireland, the Northern Ireland Rare Disease Partnership, for coming together for this North-South event. The more we can do in terms of all-island healthcare, the better. We worked very well together during COVID, Robin Swan and myself, for example, and our officials, and most importantly, healthcare workers, North and South, works very well together, continue to work very well together. Neither COVID nor any of the many thousands of rare diseases which have been identified, they couldn't really care less about which side of the border they're on. And the more of an all-island approach we can take to supporting people, to cooperation on research and development, on medicines and so forth, the better. And I'm really delighted to see this as an all-island event. So a huge thank you to both groups. Can I also just thank the Rare Diseases Ireland group. I know ye better than the Northern Ireland colleagues, and I just want to acknowledge the tireless work that you put in. You're working behind the scenes at a huge rate. You've been advocating, you've been agitating, you have been working with patients, supporting patients and their families, supporting mums and dads who are learning how to raise and support boys and girls who've been diagnosed with rare diseases. I think the work you do is invaluable. I think it speaks to the very best of us on this island in terms of looking out for each other, in terms of local community-based and voluntary supports. So I really just want to acknowledge all of your work, your ongoing work, the work you're doing into the future on the task force, on the forum and more, and say well done for everything you have achieved so far. The theme for today, I think, is very useful, which is looking to the future for rare diseases. And I know you've had good discussion already around the science, the technologies, the medicines, screenings, and so forth. And really, that's where I want to start. Is what's our ambition in terms of health and social supports for people living with rare diseases in this country? You all know that the name rare disease is correct to a point, but in many ways isn't. In that we have 300,000 people in the country living with a rare disease, one person in 17, and I was delighted to launch the recent campaign around 1 in 17. And the point I made at that launch was 300,000 people living with a rare disease, many of them children, means that probably 1 million people out of a population of a little over 5 million in the Republic anyway, either have a rare disease or are living with somebody with a rare disease. So in fact, 1 in 17 may have a rare disease, but probably 1 in 5 of us are living in a household where somebody has a rare disease. And so really it is anything but rare. We're identifying more and more of them. We now have identified about 6,000 rare diseases, which is very useful progress. And as we all know, there's tens of millions of people across the EU who are living with a rare disease. You all know far better than I do that for the person with a rare disease, life can be very difficult. Obviously, it depends greatly on the disease. It depends greatly on the condition, but it can be very, very difficult. And in cases, tragically, it can be fatal, as we know. It's also very difficult for the families. It's difficult for mums and dads who are getting on with their lives, have probably never heard of rare diseases. They certainly won't have heard of the rare disease that their little boy or their little girl has. And they need to then frantically try and find out about the disease, who in Ireland, who in the HSE has expertise in this, who in the world has expertise in this. I was talking at the launch of 1 in 17 with some parents who were saying their daughter is one of 50 people in the world who has this particular disease. And this was very difficult because they couldn't find anyone to really talk to about it. They found it very difficult to find any medics to talk to about it. And they were able through Facebook to find people and to organise internationally. And they said the comfort and the support that they got from being able to reach out with and share experiences with parents from around the world whose children have these diseases was incredibly valuable to them. So it's difficult, obviously very difficult, most importantly for the person with the disease, but for mums and dads and brothers and sisters and sons and daughters, it can be very, very difficult as well. So what do we want? What we want is a country, what we want is an island whereby we can rapidly identify rare diseases as soon as possible. Les Martin and I were talking outside. I've written to the National Advisory Screening Committee about MLD, thanks to the tireless work of Les on Spinraza, which his own son died of. I know he won't mind me saying that. He's spoken about it many times. And another 5-year-old boy, Aidan Kenny, died of not that long ago from MLD. Spinraza is a life-saving treatment. Les has campaigned for a very long time, and we got it over the line just in the last few weeks. It's very expensive, and it's worth every single penny. Les and I will now be working together to ensure that MLD becomes one of the conditions that is screened for. We want an Ireland where as many conditions as possible are screened for. We want an Ireland whereby we have the medical expertise here in the country, or in many cases where we are part of an international community, be it through the European research networks or other international collaborations that make sure if our own medics don't have the information, they can tap into the expertise, be it in the north, be it in Britain, be it around the world as quickly as possible. We want an Ireland where the people diagnosed have access to the most effective, the most modern treatments to the greatest extent possible. And the developments that are going on in the pharma industry right now really are breathtaking around the speed at which new orphan drugs, new treatments are becoming available. And critically, as we were saying outside, it's not all about the medicines, it's not all about the treatment. Obviously, that's a core part of it. We need an Ireland where the social supports, the community supports, the health and social care supports are available to those living with rare diseases. That might mean in their home, it might mean via their local GP, it might mean via their local primary care centre, and then as a last resort, obviously, in the hospital setting. That's what we aspire to. Help people, work on prevention through genetic genetic screening, which is something we're investing in, be able to identify diseases early, be able to tap into the best expertise around the world when we're looking for treatment, have access to the best medicines, the best technology, the best devices, and then support people at home to the greatest extent possible. That's our vision. That's ultimately what we aspire to. And to that end, we have taken a very deliberate and a very active approach in the lifetime of this government. I was concerned with the 2020 budget in that there was no new development funding for medicines whatsoever. And so when I was appointed Minister for Health, I spoke with the National Centre for Pharmacoeconomics and others, and I said, there's a lot of medicines which are not getting approved, and we in the Dáil have been saying that it's kind of your fault because you're too slow, you're not transparent enough, it's not happening. And the answer I got back, I hadn't heard before. The answer I got back is there's no money for new drugs. There's no allocation in 2020 for new medicines. So what are we meant to do? Give reimbursement decisions on medicines that there's no money to fund. And so we moved on that very quickly. We allocated €50 million for new medicines in 2021, more in 22, more in 2023, and this year again another €30 million. In preparation for coming here today, I asked the department to give me a rough estimate as to the amount of money that will be spent just on these new medicines, on these new allocations from 2021 to this year over the next 5 years. So how much money just on the new stuff are we going to spend in the next 5 years? And don't tell Pascal Donoghue this if any of you see him. But the figure I got back was in excess of €850 million. That's just on the new medicines approved in the lifetime of this government. We spend €1 in every 8 in healthcare on medicines, €3.2 billion. And the good news is, with this new development funding over the last number of years, just in the last 3 years, because there'll be more this year, 148 reimbursement approvals have happened, either for new medicines or for additional uses for existing medicines. And I'm very happy to be able to report that of that, a great number, 40 or 50 of those, are for orphan drugs. I had believed, in fact, I may have even said it in the Oireachtas, that there was no money for orphan drugs. There were no orphan drugs being approved, and we didn't have a system in place to deal with that. But it turns out that a great number of the new reimbursement decisions are indeed for orphan drugs, which is very good to see. Now, more needs to be done. We've published the Mazars report. We are going to have a tracker in place so that patient groups and other stakeholders, the pharma industry and others, can see how these things are progressing. We need to be able to do more health technology assessments. We need to be able to do them quicker, and we need to be able to do more of them at the same time. And for that reason, this year we've allocated additional staff to the National Centre for Pharmacoeconomics and to HICWA, and to the corporate pharmaceutical unit within the HSE, essentially the ecosystem of assessment teams in our public health service to make sure that we have greater transparency, greater capacity and greater speed in terms of assessing many of the treatments, many of the medications that are so important to the 300,000 people and all those in the future, all those people who will be born in the future. Who need all of this as well. One of the areas I touched on was newborn screening. I think it's fair to say that Ireland probably has been a laggard in terms of the number of conditions that we screen for. We were at 9 when I took office. We're now at 11. We've authorised SMA and SCID. Hopefully later this year, MLD will be added to that. We have to see what the group says. I've doubled the funding. In the initial budget, we allocated $700,000 to help with the rollout of additional newborn screening diseases. I've doubled that now to €1.4 million to make sure that we can just crack on and do it. We need these screening services in place very quickly. And this really needs to be just the start. We have a really good expert advisory group who are looking at conditions right across the board, and I fully expect Ireland to catch up. And we must really aim and have an ambition to be among the leading countries in Europe, not just at the average. We are a wealthy country. We invest an awful lot of money in healthcare, and it's important to all of us that we aspire to be amongst the leading countries in the world in terms of newborn screening. One of the things that we have to continue to support as well is the international collaborations. The European reference networks are essential in terms of us sharing our expertise and in terms of learning from those right across the EU as to what's going on in their countries, often with much bigger populations than us, often with an awful lot of expertise that they can share. We're now members of 18 of these European research networks. I think it's going from strength to strength, and it's something we're going to continue to back, because certainly there is no way we could have the expertise on this small, beautiful island of ours, rather, to be able to cover all of the diseases. We simply couldn't do it. We're taking an international approach to this, and not just an EU approach, obviously. Our clinicians have links all over the world, be it in North America, Australia, other places as well, the UK, obviously, and we're going to continue to back them in being part of an international community in terms of the expertise that's required. One of the other big things we've done, and I know there's people in the room who are actively involved in this, is put in place a new steering group. As you'll all be aware, there was a rare disease strategy, but that rare disease strategy, the timing on it ended 6 years ago now. My observation was that whilst a lot of good work was happening, we weren't taking a strategic approach to rare diseases and to supporting people with rare diseases. So I asked the department, I spoke with the Chief Medical Officer, I asked Professor Smith to set up a working group to put a new strategy together for us. And what's very important in this strategy is that whilst of course it includes access to medications, access to science and technology, it's much broader than that. There hasn't been enough attention, in my view, on community care, on community networks of support right across the board. And what we want out of this strategy is not just very strong hospital-based care. We want to make sure that end to end we have a very ambitious plan for supporting people at home and the other issues which I referenced earlier on around genetics and screening and acute care and medication and social supports and mental health supports. Key to all of this, obviously, is the patient. The patient voice must be at the centre of everything that we do. I think some parts of the HSC or some parts of our public health services have done that well in the past, but not universally. And one of the big cultural changes that we're in the middle of at the moment is saying that the patient not only comes first, but the patient voice and the patient experience comes first. Probably the most successful action plan we have launched in the time of this government is the Women's Health Action Plan. We launched it 2 years ago. We did a 2-year action plan, and we designed the plan putting in place a women's health task force. They did a listening exercise right across the country, and they came back to the department and said, these are the services that women want, be they GP services, hospital services, community services. These are the services that women are saying they want. They are the services that we put together around fertility treatments, menopause, endometriosis, maternity services, perinatal mental health, eating disorder teams, and more. We're going to be launching a new 2-year plan in the coming weeks. But the big learning from that, which we are applying now to the new rare disease strategy, is everything starts and finishes with the patient voice, with the patient experience. And I know there are people in the room, I've met some outside earlier on, who've agreed to give up their time to be on that patient forum, and I want to thank you all very much for that. I also want to thank all of you who've agreed to be on the steering group as well. I know you're all very busy people. There are a lot of different demands on your time. This is a substantial piece of work that you've agreed to invest a good chunk of your time and your effort and your expertise into. So I really want to thank everyone on both the patient forum and the steering group for agreeing to do it. I think it's going to lead to a really important strategy. It's going to lead to an important improvement in supports for people living with rare diseases. So that's all I want to say today. Rest assured, this government is listening to you very carefully and very closely. We are going to continue to invest. We're building momentum. Having the new strategy is the best way to future-proof investment. When budgets come around, when you have a strategy that's been agreed, it's been verified, it has clinical governance, it has the patient front and centre, it's much easier to say, we're going to give X million to the maternity strategy, the cancer strategy, the palliative care strategy, the rare disease strategy, rather than people within the HSE trying to work with officials in my department to say, can we have a bit of money for this thing over here, or could we have a bit of money for that thing over there? When you have a coherent end-to-end strategy, it's just easier to invest chunks of money into it, and then that money tends to get put to the best possible use with a clear strategic framework and governance. So best of luck putting it together. Be ambitious, as I know you will. I've no doubt it will cost an eye-watering amount of money, all of the strategies that come in do, but for very good reason, because those who are on those groups are demanding the very best on behalf of the children and the mums and dads and the adults and everybody who's living with or supporting someone living with a rare disease. So best of luck for the rest of the day. Thank you again for the invite, and we will look forward to a bright future where Ireland can proudly say we are one of the leading countries in the world when it comes to supporting people living with rare diseases. Gur Magwith.
Thank you very much, Minister. One of the leading countries in the world supporting rare diseases. When we get there, I am definitely going to have a glass of wine. Definitely. Or maybe something a little bit stronger. Moving on, I know a piece that is close to the hearts of many people in the room here, people living with rare diseases, family members of people living with rare diseases. It's the struggle, the daily struggle that people have, putting all the pieces together. Making sure that you've got the right appointments. Are you doing the right things? Have you had the right tests? Have you been assessed? Are you getting the right treatments and stuff like that? And that, I guess, is what Anne Lawler would speak to as the back of the ranch kind of stuff. This is the real life. This is the fact that I'm struggling on a daily basis to keep the show on the road. Maybe I need an assessment for a child for education purposes. It's all of those pieces. We're fortunate, unfortunately, not to have in the country, but we do have online, is Raquel Castro. She's Social Policy and Initiatives Director with Eurordis. And I guess this is Raquel's bread and butter, seeing what needs to be done across Europe to make life easier for people. What does holistic care look like? Raquel, I guess her day job. Hi, Raquel. Her day job is around integrated health and social care and social policy, and looking at disability, employment and non-discrimination rights. I know that she will speak to many people in the room. She will resonate with many people in the room. And I'm really looking forward to hearing what Raquel has to say. Thank you very much.
To come and to be in the same room. Thank you for the invitation. I'm very honored to speak among such distinguished speakers and to join you for this conference. So as Vicky was saying, I represent Eurordis. I believe most of you will know who we are, and I know that our president was speaking in the morning as well. So we do work across borders and diseases to improve the lives of people with a rare disease. And we have over 1,000 members, 15 in Ireland, including, of course, Rare Diseases Ireland. And we have the vision. I'm very happy at the same time as feeling the weight of speaking after your health minister. At the same time, I'm very happy to speak after and to hear about the ambition in Ireland, and even his call for us all to be ambitious. Because our vision at Eurordis is quite ambitious, and we really want everyone with a rare disease to have better lives, not just longer lives, and to achieve their full potential. And this is where I'm going to focus more. We're so ambitious that we have a position on holistic care, which is quite ambitious and still far. We did it until we thought by 2030 we want to have all these things, but they might not all be there. We went as high as we could. We aimed as high as we could. And within that position of holistic care, there is one essential pillar on integrating care. So really, as Vicky was saying, on bringing all those pieces together. And as our president mentioned this morning, Avril Daly, we also are calling for the EU action plan with the support also from Ireland. And in that, we also, of course, include this priority of making sure that fully daily life issues and living to our fullest potential is included also in that EU action plan. So I was very happy to hear your minister speak now, and to really, and also this morning to hear more about your ambition towards your future, your upcoming plan. And so to know that you want to ensure that people with rare disease and families have the right care at the right time, at the right place, is really reassuring, and I'm very happy to give my small contribution to that. So I do have some slides which I will try to not kill the wall by PowerPoint. So hopefully you will see them now in full screen. So I'm just going to speak a little bit about why integrated care, but there's so much to say. And Vicky was just saying, what does holistic care mean? And I think it means something potentially different for everyone. So potentially something different for every 1 in 5 that your minister was just saying, that probably is living with a rare disease in a household with a rare disease, right? Because when we're talking about holistic care, we're talking way beyond the person themselves and talking about the whole family or the closest ones that live with that person or close to that person. So it's a very broad area, and of course it's quite challenging, and it does mean something different for everyone, or at least no one's life is equal to another one's, regardless of which disease, and whether they live with the same disease, and whether they live in the same area of Ireland or not. A reminder is that we conducted an European survey a few years ago around these issues of daily life, and I know many of you in the room know this, so I won't actually go through it. It's overwhelming just looking at the slide. But rare diseases do have an impact across really different areas. They affect our functioning. People have challenges with daily tasks, relations, communication. It's not the same number of people for everything, but it's a very high number of respondents to this survey that had difficulties with different areas of daily life. And this goes beyond. Some of these might be addressed by treatments or healthcare, and some are not. And here I would like to focus a little bit more. So in the same survey, we actually saw that 65% of the respondents, which is not surprising to any of us, had to visit different health, social, and local services in short periods of time. So we all know that. The problem is, what do we do about it? But we'll get to my small contribution to that. And we also heard from the respondents, so they were either people with a rare disease or a family member, that 67% of them felt the services communicated badly with each other. 7 in 10 also didn't feel well informed about their rights, which obviously makes it difficult to access them. And 7 in 10 found that organizing care was time consuming, which again is not a surprise to any of us, and hard to manage for 6 in 10. So, as Vicky was saying, all the things we have to manage daily. And the consequence of that, and there were many in the survey, but obviously I know you know a lot of them, so I'm just going to highlight some of the consequences, is the time spent on care is, or managing the things that come with living with a rare disease more directly, is significant. And considering we all have 24 hours a day, if you're spending more than 2 hours per day just to manage things around your care and your condition, that's quite significant. And as a consequence of that and many things that we live with, 7 in 10 people with a rare disease or family members have to reduce or stop professional activity. And this is huge. So when we think about what is the importance of professional activity in our lives in terms of obviously personal development, satisfaction, but our economy, our social participation, etc. This is huge. And we also compared ourselves in that survey. We used a question from that was used in a general population survey in Europe, and so we could compare ourselves in terms of mental health to more general population. And we see that people with rare disease and family members reported feeling depressed 3 times more than the general population. So these all and many other things we saw in this survey come all from the many aspects of living with a rare disease, and the fact that our care pathways are still, and our care is still not there yet at what we would be our ambition. And actually, a few years ago, we already had the fortune to be involved in the drafting of European recommendations back when there was an expert group for rare diseases that was coordinated by the European Commission. And there were some recommendations that initially, well, actually, they were still called like that. They were focused on incorporating rare disease into social services and policies. That was the point of departure. And they ended up being recommendations very much about multidisciplinary, holistic, person-centered care, and not so much about social services as such, because we realized that we were in a sort of a ping pong between health and social services when it regards to things that are daily life generally and not necessarily directly healthcare. And it was this ping pong led us to think integrated care has a huge role, amongst other things, to really make us have better lives and live our full lives as we want. Now, how to achieve it? That's the million-dollar question. And I don't have the answers. But there are some things that at least we've been over the years discussing with experts, and through projects we've been in discussing with different people from different countries and taking good practices. We've identified a few things that we think are essential. So one is having integrated health and social care pathways. Very easy, not ambitious at all. And of course, making them person-centered. And that's we talk a lot about person-centered, and even within patient organizations. And it's quite challenging because person-centered means individual. And as I was saying before, people don't want the same things. People don't live the same way. It doesn't matter which condition, etc. So of course, it's a challenge to make it really person-centered. And we also need it to be lifelong. We know it cannot stop, and it cannot have the huge hurdles between pediatric care and adult care, for example, as we still have. And it needs not to be just about care, because sometimes care is Care is essential, obviously, but sometimes it's also it's not everything. There are some things that are not really care, they're just support, or they're just things we want to do and that we want to be able to do, but it's not necessarily that someone is caring for us. And one of the things we're very keen on at Eurodis is case management, and there's a reason, and I will tell you a bit more why. I did also speak at a meeting in Ireland a few years ago about the same project, but we didn't have the results yet back then. So if some of you were there, you'll have something new. And training of professionals, of course, is essential. And we talk a lot about training. We usually talk about training in healthcare, but training of professionals outside of healthcare, education, social, is as essential. And then lastly, I mentioned disability assessment because it's something we're working a lot on or trying to, because we've realized that these procedures to actually access disability rights and support that is available for persons with disabilities, and many of us live with disabilities, that these processes are essential to access certain rights, and that many times the information that comes from the medical side is quite essential to these processes. And this usually happens outside in another area. So there's a lack of coordination still between these processes, and we do hear from the community that these processes are not working very well for people with a rare disease. So I'll just tell you a little bit what we learned from the project I've spoken to you about a few years ago, a European project that was, amongst other things, implementing a pilot of case management for rare diseases, which was in Romania. And so the project, besides that, there was the opportunity to have actually multi-stakeholder workshops. So there were over 100 people from 24 countries involved in the project, which was quite rich. So beyond the project that was implemented in Romania, we could really have discussions at the European level on what's working, what's not working, what would we want, and how do we make integrated care a reality for people with rare disease. So in regards to the case management pilot, the project defined the case management as the objectives as to improve. So by implementing case management, we wanted to improve the person's or their family knowledge on their disease, their rights and the services, the capacity to manage their own care on what they can in terms of self-management, their communication skills, notably to explain their condition and their care needs. Also, to help them connect more with others with the same condition, to support the coordination between different care providers. Of course, that's one of the high objectives of case management, to raise awareness and understanding of the community. So that was a marginal associated objective, and to prevent avoidable risk situations and optimize the use of services. So this is how it was defined. It was implemented in Romania for 18 months in one region in Romania together with the county, and at the Noro Center that I know some of you will know, the resource center that is in Romania, managed by the Prader-Willi Association and hosting also the National Alliance in Romania. So managed by patient organizations, but it is a center that has therapies, rehabilitation, training, health and social services, and in protocols with the authorities as well, and is a member of ERN Ithaca. So the project was developed there, and with input from in different ways to really shape the pilot the most meaningfully possible. There were 121 people involved in receiving the case management services across ages and various rare diseases, and 2 full-time equivalent case managers employed. Actually, 4 people were employed, but the equivalent to 2 full-time. And they were, I get this question a lot, and so I thought I would mention these. Specifically, these case managers were social workers, a legal advisor, and a special education teacher. But we have also known of case management projects more often, actually, using nurses and being run from the hospital side directly. So we don't promote one specific model of where the case management should happen and who should be the professionals. The most important is how the service is structured and that it functions in your context in your reality. And each case manager had a maximum of 30 people at the same time. Defined within the project was the role that they would have. So they would be the main point of contact for the person and the family. They would be, of course, providing information, support, and empowering them, being a hub of knowledge, and also being able to really assess the needs with the person and the family, and to help them with holistic and person-centered care planning and coordination. And the experience was evaluated through an experimental design. You will have then, I actually was hiding a lot of the slides to avoid providing too much information, so you will receive them fully and have access to the charts with the results and also the full evaluation report for download. So it was evaluated through experimental design. There were two groups. One group was accessing the intervention the first 9 months and the other was not. And then it swapped. The group that was receiving intervention in the first 9 months discontinued for the next 9 months, whereas the others started. So it was possible by measurements before, during, and after the intervention to compare between the groups and within each group how the evolution was going. And different quality of life measurement generic instruments were used for the evaluation, and then some specific instruments tailored to the objectives that were defined for the case management. There was also additional research on upscaling this project. So how do we do case management? What's really important and what's really important for integrated care? Now, what the results that we didn't have last time when I spoke at your conference is that the case management service improved the beneficiary's level of information, something we could expect. It also increased their communication skills and improved coordination of care. And it increased the capacity to manage their own care and decreased the burden of family caregivers. And this was measured using the Zarit care burden instrument specifically. More adding to that is that the improvements, so as I said, one group had an intervention for the first 9 months and then it stopped. So the improvements that they had obtained during the intervention were sustained in the next 9 months because they were measured again, their situation at the end of the 18 months. And so we could see that. And there was less use of emergency hospital services and also less hospitalizations as a side result of this intervention. So you will have, as I said, the charts and the full report to download. But also when we talk about numbers, sometimes it's not very concrete. What does this really mean? So what really changed for them? So the evaluators, the team that was evaluating also collected some actual stories to try to understand what, by having a case manager, their help, the information, knowing about their rights, what changed. And so we saw some people, for example, got access to a personal assistant or to a wheelchair after having spent time looking for that type of support. Some others were able to access employment, rehabilitation, peer support, thanks to the information and the care management that they were able to do with the case manager. And this is quite important to have this qualitative view of what it means for people and not just measure it quantity-wise. So I wanted to say that I'm quite excited because this project ended in 2018, as you've seen, and since then we have been talking about case management as much as we can. And fortunately, there are different countries starting to do it or doing pilots and even evaluating them. And we are very excited that the upcoming joint action to integrate the European reference networks into national healthcare systems is going to contain a piece of work on guidelines for case management. So again, at European level, now involving experts in case management beyond those that were involved in enough care and also with more recent experiences, to advise also on the integration of these topics in national workshops, so which will be extremely useful, of course, for all the progress on national plans. And we are very fortunate that that work is going to be done precisely with two colleagues, and colleagues specifically from Ireland, so with Professor Eileen Tracy, and also with colleagues from Lithuania. And so it's something coming up, and where we expect and hope to really progress and to really be helpful to different countries, and of course to Ireland in this type of interventions such as case management. I'm just checking my time. So how to achieve integrated care? As I said, I don't have the answer. But I really stick to this. We've tried at Eurodis to say there's so much. We have our position paper on holistic care is 40 something pages, which I'm sure nobody reads. And we try to, it's really interesting, but it's very long. So we're trying to see what are the things that could change the most the situation, and that could be the most transformative. And so we stick really to these that I've mentioned before, but also in of care, because I said there was this work about upscaling. So about thinking, how do we do integrated care elsewhere, case management, other ways. And three things were identified as really important: coordination between public bodies, which I thought was worth mentioning here, multidisciplinary teams, and care coordination. And please do note, when we say multidisciplinary teams, it does not just mean inside healthcare. It means bridging the door of the hospitals and of the healthcare services. And the empowerment of people with rare disease and their families. And there were actually extensive recommendations, which I will also provide slides and link after, around how to implement integrated care. And what's interesting about this is that it wasn't just urology. So it wasn't just coming from patients. As I said, 100 people were involved. There was an advisory group of 17 people of national authorities from different countries. So in that sense, it's quite interesting. And I wanted just to mention a few before I conclude, is that, for example, there was one specific area on creating a supportive environment at national level, with several ideas and things that have worked in some countries, and so including interministerial working groups, shared budgets between ministries, so really ensuring that the plans for rare disease and the integrated care for rare disease is not sustained by just one ministry when they are different ministries. Also having top-down and bottom-up approaches, so really making sure that it's quite comprehensive, and including, of course, integrated health and social care in national policies, and specifically in national plans, which I know you are planning in any case for the upcoming plan. There were also mentions to financial and structural support to the platforms and networks that really work as collectors of knowledge and good practices. And of course, we do think of the European reference networks and their respective members at national level, but also organizations and patient organizations and other services sometimes act as such platforms. Of course, pilot projects would be great to test some of these issues like case management. My recommendation for that is always, when implementing, really making sure there is an evaluation that is thought of from the beginning, so that there's really more knowledge on the impact. Training of care providers, of course, as we said before, is essential. And also there was this, some countries have this, that coordination between care providers is required already in public tenders, so to obtain funding for certain services. And lastly, there were some mechanisms on integrated care and empowerment mechanisms. And of course, there were recommendations to implement case management, seeing the value that it has, but also, for example, resource centers. And I did not speak too much about that, also for the sake of time. But there are some centers in Europe, for example, Ogrenska Center in Sweden, you might have heard, or Frambu in Norway, or the center where the Care pilot took place. And these centers take a very holistic approach. They're not they're not hospitals. They're not really social services. There's something in between and beyond. And they are quite interesting models to look at, even if they can't be necessarily replicated in every country, and obviously there's a cost to that, but it's quite interesting to learn from their experience in terms of also the support they provide to families and individuals in terms of training, mental health support, managing the condition, and beyond that. So there were different suggestions within enough care that are beyond what I was presenting here, that are still valid today, and depending, of course, on what you have implemented and not in Ireland, might be more or less relevant, but still quite to be achieved in many countries across Europe. So I'm happy to provide after further resources on that, of course.
Thank you very much, Raquel. That was very interesting, a lot. I'm a little bit disappointed that you don't have the solution ready for us. I thought that you'd come with an answer and we could all just, do another couple of weeks of work and then we can all go into retirement, but sadly not. I would like to invite up my panellists here. I have Lorraine McGlinchey, coming to us as a family member with rare heart conditions, and Lorraine is around somewhere, I'm not sure where she is. She's coming, there, I see the arm up in the air. Lorraine is also a European, one of the EPAGs, the Irish EPAGs in Guardheart, ER in Guardheart, and is an adult nurse lecturer. Yep, please, thank you very much. David Keegan, a consultant ophthalmologist at the Mater Hospital, and not to denigrate any other healthcare providers or clinicians in the room, David, I always find, has a very interesting angle on his challenges of making sure that his patients receive the kind of care that they need. He has given a lot of thought to it and is always very enlightening and inspiring, I believe. Alison Moore, who is the I think the rare disease clinical lead, probably actually the children's rare disease clinical lead. It is adult, okay, sorry. Adult rare disease clinical lead coming from Northern Ireland through the Belfast Trust. And Ciara Martin. Ciara is still here, yes. HSE National Clinical Advisor and Group Lead for Children and Young People with the Office of the Chief Clinical Officer, so in Colm Henry's office. So I'm not even sure where to start. What I will say is that the reason that I'm here, sitting at this table as the chair of this group, is it was extraordinarily difficult to find anybody who could really say, you know what, yeah, I'm happy to speak about this topic. And I had to hoodwink and browbeat some of the people in this room. And I think it's a reflection of, we all know that something needs to happen, but none of us are quite there yet. None of us are quite at that stage of saying, yeah, I'm going to lead out on this, I'm going to make this happen. And, I would hope that over the next 3 months or 6 months, we can really have some really good conversations on what needs to happen and how we can do it. Back to Cecily's implementation plan. What are the moving parts? Who are the people that need to be involved? And that this time next year, if we were in the same position, that there'd be 10 people saying, yeah, I'm here, I'm ready to give it a go, I'm ready to do it. I'm going to start with my first question for Lorraine. What is integrated care from somebody who's living the experience? What would you like to see?
I suppose, I can see it from a lot of points of view. I can see it from a family perspective. We have a condition in our family called CPVT, which I know Alison will know about. It's a catecholaminergic polymorphic ventricular tachycardia.
For those that want to know.
Thank you. Not the cardiologist in the room, but so it's difficult to say, but it's also rare. And unfortunately, CPVT, which is the short version for it, causes sudden adult death syndrome. And as a family, we've lost 7 people to CPVT or to SADS. So integrated care to me means not having a stopgap from here, from A to B. I was asked this question this morning because I was at another conference. Who do I turn to? For somebody who's getting a new diagnosis, or they just, as was said earlier, a bombshell of, you have a diagnosis of this disease that you have no idea what it is. Sometimes when you're getting the diagnosis, you don't even hear what's been said. You've heard this word, that's it, everything else goes over the top of your head. Who do I contact? Who do I go to? Who do I even go to find out the contact? Who's going to support me? Who's going to look after me? Who's going to look after my family? These are all the questions that we need to be able to have on the ground for families like ours that absolutely have no idea where to turn to next. They just find this diagnosis sitting right in front of them and they have no idea where to turn. So I am also, should I say it, I'm an orthopaedic nurse, so why should an orthopaedic nurse be very much into cardiology? But as you can see, I have a thing on both. So I can see from a nursing point of view, I will, refer patients out for, for follow-up in the community or whatever. We need to have all those links in place to be able to know who to put that person in contact with, and that they will be looked after as a family as opposed to one person, adult or children. I know that might be a very long-winded way of saying it, but not only that, then it's your support groups. Say like for an instance in ours is like the of CRY, CRY Ireland, the Irish Heart Foundation, or the fact that I'm the representative in Ireland now for these rare arrhythmias. So I can link back now into Europe to be able to get the care and the support, both from the clinicians but also from the patients and the families. So we can link now out through Europe as well if we need to have that as well.
Mm-hmm. David, I see you busy making notes there. If I pose the same question to you, what is integrated care? And it's a question that we actually have discussed with Derek previously, and where the Rare Disease Patient Forum as part of the strategy. It is the first question we need to ask people. What does it look? What does it feel like? What does it look like? What are we actually trying to do here?
I think Lorraine's brought us through is a lot of those challenges to delivering integrated care. So with integrated care, I always preface this as just an ophthalmologist. So if you want a real doctor, don't ask for an ophthalmologist. But with regard to integrated care, it is exactly, I think the talk from Raquel was just really summed it up. I found myself snapping slides. I'm supposed to be sitting on an expert panel here. I sit in these expert groups. But actually a lot of what Raquel distilled into is that integrated care. It's that because, and it's one of the challenges we've had in ophthalmology, and Avra will know this, to framing a national vision strategy, which we did many years ago, because the pathway that came out that time was all around acute hospital medicine. And Raquel alluded to it in her talk. There was nothing about that pre-hospital piece where they might go to an optometrist or talk to a friend, talk to the GP, and there was nothing on the other end about post-acute care, rehabilitation, low vision assistance, when you've maybe done all you can or there was nothing to do in the acute hospital setting. And that then funnels right back to the lived experience of patients, and through my own involvement, well, from knowing Avril for years, but through Fighting Blindness and now Vision Ireland patients, that shocking lived experience of their first encounter with a healthcare professional never leaves a patient, never leaves. If I'd learned one thing as a clinician being involved in it, is that piece. So there's integrated care failing right then and there, is that patient's first memory is that interaction of somebody who doesn't know what they're talking about, doesn't have the honesty to admit they don't know what they talk about, doesn't know the pathway maybe to put the patient on to help assess that, or all the other pieces around it. But we can't know everything. So, sorry, I'm going to come back and answer your question directly. Integrated care is all the bits that Raquel talked about in that talk.
Yeah.
Right from the start, the awareness of an issue, whatever that is. I mean, maybe arrhythmias, it's just that awareness of that flutter. It doesn't have to be the sudden event, but actually generally you'll find that there's something's been happening prior to that. And then knowing where to go. So that's what I was jotting down here.
Yeah.
It's an awareness program. If where appropriate, it's a screening program. Then you got to decide your population. Are you going to wait for this opportunistic show up? Then it's into your care program or prophylaxis program. But then you need your support mechanism in place. Then there's a post-treatment program. Raquel talking about the psychological aspects. Sorry, I'm talking too much, but it is all those bits, and we have the support.
I think actually one of the things that you just said there about that first interaction with your clinician, And I would suspect, Raquel, it's a similar reaction or a similar approach in Europe as we have here in Ireland, that our clinicians are all-knowing and on a pedestal, and if you're now falling off that pedestal in our world, and therefore this is devastating, this is worse than I thought it could possibly be, because I thought you were going to answer all of my questions. And I wonder, do we all need to kind of like, actually, I think back to Mary Carney's earlier conversation around there's 6,000 plus rare diseases. We've got to be able to acknowledge they're not going to know everything about everybody and about all of these conditions to the level of detail. And so it's trying to make sure that we as a society recognise we're not infallible. Our clinicians aren't all knowing about everything, and therefore we have to give a little bit of that, and maybe then that experience isn't as devastating as it could be. Or as some people, as it is for some people, I should say. Alison, I know that you're, I think, relatively recently in position in the north, and I'm sure there's about 1 billion moving parts. And now that you have a Minister for Health in situ, there's 1 billion and one, and that one is the most important one. When I discussed with you again, please do something for me. You were talking about, we're in the job of embarking on care pathways, and that's a piece of a component of it. How's it going? Are you having? I know that we've done work here in the south on care pathways, and it's been an eye-opening experience, I think, in terms of the patients, what the patients are saying about what they're looking for. Are you getting the big challenge we have here? Commissioning. Are you getting commissioning? Are you that far along? What's going on with care pathways as a component of the integrated care model, I guess?
Yeah, so I guess what we've started with are services that are currently in place to varying degrees. Can I just say I'm really impressed with how quickly you managed to put my name in the programme, because I know when I agreed to do this. It's impressive. Get you to come and sort my care pathways. So as part of the work in Northern Ireland, what we're trying to do is learn from services that are in various stages of development already, but those care pathways are not documented clearly to be shared with our colleagues in primary care, to be really visible to patients, to know what the pathway is that they have to follow. I would add on to that first patient interaction, which is terrifying. I think once they've been given the diagnosis, it's actually, going back to what the city said this morning, it's nearly more terrifying that they've come back for their 10th visit and they still have to explain what the disease might be. And I think that's a component of, we have to respect that patients are experts in their rare diseases, and they have to be allowed to tell us about their rare disease. And that it's not an education piece to teach a doctor about every rare disease, because that's impossible. But we probably, as part of our education, need to teach our trainees that actually our patients can teach us, and it's okay to say, I don't know the answer, but I'm going to go and find someone who does. And so the work that we're doing at the minute is in a group of six adult rare disease groups, a slightly different but overlapping group in paediatrics. And we are working through creating complete service specifications and documenting complete service specifications as to what the service should look like on paper to deliver the whole care of that condition. Within that, then, there are the pathways of how primary care will refer in, how patients can refer themselves in, and the transition piece, because we know that collectively, as doctors, we don't do transition brilliantly well. We all try very hard, but actually you go from that bosom of love and bubble in paediatric care to the big, horrible world of adult medicine, where there's just not the capacity to treat patients the same way. And so it's trying to transition that. And so one of those things that we've done, certainly in my... So I'm the adult rare disease, but by trade I'm a cardiologist. So I'm a genetic cardiologist. I look after inherited cardiac conditions. And one of the things that we've done is that I try to meet the children and their families at a family clinic, because parents and children are affected with the same condition, so you come to the one clinic. And then you transition over to adult care, and we've introduced this thing now where you get a letter which will say, you're now my patient. If you have a problem before you meet me, it's okay to still phone me. I'm your doctor. So families know who they're looking after. And we're trying to get these overarching principles of transition embedded into all of our care pathways. We've published a paper on this sort of the higher level themes of transition, and then they're all going to be embedded within the care pathways that are being written at this minute in time. And alongside that then, after discussion with the gentleman, I can't see him now, I talked to him earlier about making sure we have access for patients to get information, links to the relative charitable agencies for their disease, and trying to link up all of that as a whole piece. We're starting with services that are reasonably well established, simply because we've got to walk before we can run, and we have our commissioners on board with us, and we're getting those services that are already in place well documented, learning what works well, what doesn't work well, and then we will branch out in the coming years to other services that are not just quite so far down that pathway.
Okay. Thank you.
Does that make sense?
Yeah, no, it does. It does. It's a journey. It's a long journey, and it's not going to happen overnight.
This time next year, we'll have loads of care.
Ciara, we've had an integrated care programme in the HSE for a number of years at this stage, and when I look at it, and I look enviously at the HSE website, and I kind of go, wow, we have clinics around the country for different common rare conditions. We have the expertise available in communities around the country, and I don't expect that to happen for all rare diseases. It's just not practical. We're too small a country. But I wonder, in all of the work that has happened previously or to date in those areas, there must be learnings that we could say, you know what, yeah, we can, there's an expert centre located in Galway, and we know that all of these people can travel there, or there's some people that can't travel and we need to do something. There must be learnings that we can do around what has happened already, that we could actually say, it's not as difficult, because we keep on talking about it's complex, it's hard. It's kind of like, as I opened earlier on, it's kind of like, it's the human condition. It's actually just people talking to one another and working out. And every single individual will be different, and it's not because of their clinical diagnosis or their epigenetics or their phenotypes or their what all of those other words. It's actually just, I have access to a car, I have a child to pick up, I have, my bank manager is on my back. Those are actually what make us all individuals as well. So I don't know, is there stuff that you could say, yeah, we can bring stuff when we get the team in place, and that'll probably be part of what we're looking for with our implementation plan, is to get a team in place to be able to do that. But are there quick wins, do you think, for us in this area?
Well, now, to speak for the whole HSE and say there's quick wins, that's tricky. I think what you're referring to is really, I think it's really important. So I think with the HSE and integrated care, it's like everybody else, it's on a journey, and starting with, as you said, the quicker wins of the bigger chronic diseases and moving care out into the community has been really important, and feedback from that has been really good. And it was that we have to show it can be done. We have to show it can be done, that you can work with community people who work through hospitals, through communities, and be effective and provide care for patients and families. And as well as that, we're very connected with the kind of international approaches to integrated care. And one of the big learnings for me, I'm a doctor background, pediatrician, was that realization that actually a patient's care, less than 1% is provided by health professionals. There's three of us sitting up here, and yet it is the parents, it's the carers who provide 70% and then the NGOs and community primary care. And really that's where we need to be working. And to do that, what we need to do is break down a lot of the silos that have grown up with an organisation within, even, like the HSE and the way it's funded. And I think some of the changes that we're undergoing at the moment are going to be really beneficial for us. The fact that we're breaking down into regional units. We've broken down the barriers now between acute and community, so there's one person, you know, or one group looking after everybody. And we're also learning from that kind of our public health colleagues. They're on board with so much of what we're doing, and it's all of that population health needs approach. It's slow, but I can see, even I'm in post with Dervla and Abby about 2 years, and I can see that there is a change. And like that, it has to break down that barrier to say it shouldn't matter, you know, if you come with one rare disease, to say, oh no, the only place you can be looked after is, and I'm a paediatrician, is in one clinic in CHI, whereas actually what you need is a speech and language therapist who might be closer to home, who can certainly link with your specialist but provide the care you need. So I think it's a long-winded way of saying it's a journey. It's started, and I can see a change that's there, and I would hope that it has to benefit everybody. Yeah. And we do need to be breaking down all of those barriers.
And can I ask you, Cecily spoke about, when she was speaking about the interest levels that have come to her around the rare disease strategies. Oh my Lord, you know, there's people knocking on her door. Are you getting that from your colleagues? Is there an interest in there of kind of like, you know, these are the difficult but interesting cases. These are the ones, the challenging ones. Or is there a kind of like, oh no, run for cover. Let's hide away from this. It's more out of interest. How do we make this be? Because I do feel that, you know, the generations that are coming through med schools and through nursing, they see opportunities. You know, I look at all of the I guess, the industry in the room. This is, you know, what everybody is interested in. We're all talking about personalised medicine. We're not there yet, but it will happen at some stage. And I guess if Elon Musk had his way, it'd be happening tomorrow or the next day. But, you know, it will happen. And is that seen as being a real opportunity that excites people? Or is it seen as being a kind of like, oh, let me out of here. I can't, it's too much.
I think certainly working with the Chief Clinical Officer and in clinical design and innovation and integrated care, any opportunity we have to raise patient care awareness, and the work that you're all doing in the room to, you know, whether it's with individual rare diseases or as Rare Disease Ireland, of course it's welcome. You know, we need advocates, we need people who are in touch with our politicians and our departments of health, and it is really a matter of everybody will rise together, hopefully. So I certainly, in the area I'm in, I don't see it as, you know, a burden when someone rings you about something unusual.
No, I wouldn't even say it's a burden. Just, you know, I guess historically the politicians have maybe gone running because they just see dollar signs or euro signs when you say complex, and I think it's not the right mindset to have. That actually it shouldn't be. It's, you know.
Exactly.
Anyway, I won't ask you to speak for everybody.
Yeah, no, and I think you mentioned earlier when you were saying, you know, it's getting to the bank, getting to the school, getting to the parent-teacher meetings, you know, no matter what you have, they're all part of your life, and it came through in a lot of the talks today. So, you know, what the genetic component of your disease is, there's no doubt that we all need health and social care, and we need community care, and we need education involved, and we need to be getting better from the ground up. And also valuing I'm a paediatrician and I work in child health, and it's valuing every stage of childhood. And, you know, we're doing a lot of work on that transition to really value our young people as young adults, not as people who are going to be older adults, or, you know, to really have every stage mapped along the way. So it's all that kind of central, patient as centre, but recognising that patient has to grow on a life journey too.
Okay. David,
Vicky, you should have warned here there was an opportunist on the panel. I don't really want to call you out in front of everyone in the room. We've got 3 pathways that are looking for funding around rare syndromic eye diseases. So I'll drop into your office next week.
You can. I have no funding, but I'm happy to talk anyway.
I was actually going to come back to you, David, anyway. I guess stepping out a little bit, you know, we need to acknowledge we're a small country, population 5 million. We're not going to have expertise in everything. The ERNs that Raquel speaks to, that we've all spoken to, that have been in existence since 2017, and I know you've been involved in and are now leading one of them in the country. Are they all they're cracked up to be? Notwithstanding, I know the need to have better data and, you know, supports around it in Ireland. But, you know, what you see happening in Europe, is it really going to be pretty good, or is it just not going to really?
It's a really good question. And I think it's a really good question. Remember, the Irish participation in the ERNs was hampered by our political circumstances in 2017, 18. Yeah. So just one ERN got launched. So the other 16 the Minister talked about are only in about 18 months. We're not long in that system. So I'll answer, I heard about at a European level, are they, I'll come back to that second. At an Irish level, there's still more we need to do to support the ERNs. I think it'd be remiss of me to sit on this panel and not speak on behalf of all the ERN leads in this country, which is 18. There's fundamental administrative data management support that's required to meet the legal requirements that we're obliged to be members of the European structures, the ERN. So that has to be said. Eileen Tracy and the Rare Disease Office have done a huge amount to try and advocate for that funding. It hasn't come through. And I know it shouldn't always boil down to money, but some things just, and it's a modest ask for that. That's from the Irish perspective. That leverages us up to adequately meet our audit needs. Irish members are very active members of the ERNs, and that's evidenced across them. And I know Avon would have familiarity across all the ERNs, and Eileen as well. We're very active in the I one. Now, going back to your core question, will the ERNs deliver what they purported to deliver? We're definitely in a better position now than we would have been without them. I think people came into them with mixed expectations around achieving sort of research goals versus clinical goals, and I think some people drifted a little bit away when it was very much as a European collaborative clinical project. It should really be seen as replacing the treatment abroad for diagnostics, and to avoid that. I would have to say probably hasn't caught fire, and some ERNs will be better than others around that. The establishment of the registries, and really only one of the ERNs has a really good going European registry at the moment. We're fortunate we've been allocated as the centre for the I1 here in Ireland. So while that's nice for the group, but I think it starts to bring some of that expertise in and a little bit of that funding. And then to realise the full dream of the ERN is that access to that sort of high level, same standard care across Europe, be it towards genetic testing, genetic counsellors, resolution of very difficult decisions. That's a little bit away. And I think all the groups are looking to do audits of where Europe sits, where all the countries sit as regards different services. We just completed one now for, say, low vision rehabilitation support services across Europe. So the difference is huge between Ireland and France and the UK, but then you go to Bulgaria and Romania, and it's different. So there's some basic building blocks we need to put in place. If let flourish, there's a lot of bureaucracy. If let flourish, they'll get there, but I'd still say that I can't think of a better phrase. I mean, Avril's very involved in them as well, and many others in the room, probably yet to catch fire. Would that be a fair phrase? But
Lorraine?
Embers.
Yeah, I would say so, yeah, because from my point of view, the Irish, the cardiac arrhythmias end up at the Guard Heart. I'm only in the ERN now as an EPAG for a year, and that's the first Irish EPAG that has been for, as far as I'm aware, for the Guard Heart. Yeah. So we are only sort of getting up to speed as well in that area. So, but I can see that it will do a lot of good, and now that we actually have a board meeting now in Paris next month, so I'll be going to that and hopefully getting, you know, to be able to put more input, but get more back as well, that I can bring the information back with me to see what we can do here in Ireland for the patients and the families as well, for their care going forward.
Raquel, I'm conscious that I still have you sitting there and you're diligently paying attention. I am wondering, Raquel, I guess not to put you on the spot, Avril won't hold it against you. Where would you say we start? I mean, like, what is the first step? I mean, you've heard the conversations here that, you know, there's bits happening in areas where there's a bit of expertise and stuff. But, you know, I guess I've looked at a study over in the UK, the Concord study. I don't know if you're familiar with it. And, you know, are they slicing and dicing it in a manageable way, do you think? Or are they missing the big picture? Or, you know, I guess I'm at a bit of a loss as to who's going to be. Maybe, Raquel, you want to relocate here for a year and you can help us to get everything off the ground. It is a green country. What do you think?
Well, certainly. I should at least make it to one of the conferences in person, second time online. Well, I think it's very interesting all that you're doing and that you're mentioning, and I fully understand and support the approach of starting with what's already there and going step by step. It's obviously a very big mission. So I don't have a place to start, but I have a place to not finish at. So that's really counterintuitive to your question. But for me, what I see is that there's always a risk that we overly focus on the conditions. And so on how the pathways work in terms of healthcare, and then that we miss to go beyond that. And obviously that's very challenging. We can't know everything. And so it's really more understanding what kind of mechanisms or roles can there be to help with those transitions and those links, rather than thinking that there's a solution where all that will be sorted in 1 minute. That's not going to happen. But it's just thinking that for example, when we looked at case management in enough care, it wasn't specifically for a rare disease or a group of rare diseases. It was across rare diseases, which sometimes is not an approach we might think of, more medically thinking. And so the case managers were trained in a way that they had skills on communication and where to find things, but they didn't know about every rare disease. They knew where to find the doctors, where they existed. They knew where to find the resources, who to reach out to in order to make links, but they weren't experts on the medical conditions, for example. And so this is one of the examples, because if we think of implementing, for example, case management, we will think this has a cost. We need to employ people, or we need to take people's times, already people who are employed, allocate some of their time, etc. And then if we do it by specialized units within healthcare, then it becomes, and I think it's also looking at the approaches where they are sort of process approaches that might work across groups of people with rare disease who might be supported within the same hospital, for example, of course, or in different hospitals. But thinking of solutions that might be serving a wider population and not necessarily try to make everyone an expert on the conditions. So that's one thing. And the other thing is thinking of the people as individuals, which I know is extremely tricky, because we want to have the pathways, we want to have the links happen within healthcare and beyond. But then we really must not forget to ask how people actually want to live and what their choices are, and to support them in those choices, and not the standardized pathways that we had to develop to make things work. And it's good that they are there, but to make sure that people actually really have a voice in saying what they need.
Yeah, I hear you. I'm going to open the floor to one or two questions. If anybody, I see Alan Finglas has his hand up here.
Just a couple of thoughts in terms of where we could start. Some people might be familiar with an assessment of needs program for children that have developmental delays, and it's a reasonably good system where they assess the needs. And they sit down with the family, they talk about, and the patient is assessed by experts in those need areas. And if we had something like this to try and, as a starting point to try and provide integrated health and social care, I think that will be important. And obviously that will need resources to be able to do that. But I think if you don't sit down and listen to the patient family, you're not going to do anything. And we're kind of in Ireland trying to go from zero to somewhere. And so that would be my first thing. And then the second thing, which is kind of woven in with that, if a particular condition, if there was a care pathway or care guidelines, I prefer to refer them to as, for that disease, that the family and the healthcare team would sit down at different intervals and review those guidelines. Because if my son was diagnosed 9 years ago and I sit down and I read the guidelines then I read them after at even 1 year, 2 year intervals, you're going to see different things on that. And now you're trying to provide care based on evidence and not care based on symptoms. Mm-hmm. So they would be my two wishes to go from zero to somewhere in this regard. Thank you.
Yeah. Thank you, Alan. Thank you. It's a good starting point. It's an under-resourced one, I suspect. Good one.
Hi, my name is Miriam Martin. I've come down from the north. Okay, so I'd like to welcome everybody here, the new people. And I would like to say I'm from a neurological charity, Sringo Ireland Carry Association. I like to hear, I've heard a lot of good stuff here today. Congratulations to everybody who's put it together. I like what Alison had to say about the transitioning for children to adults and about being told, you're now my patient. I think there's also a gap when people transition in their senior years, and it's something that people are not even aware it's going to happen. So many people are managed in the community, and they have a team looking after them, and then coming up to their 65th birthday, they're told, you're no longer going to be my patient. That's very tough for somebody who's built a relationship and has received good care. And I think it's something that should be planned for and dealt with delicately, rather than somebody it being handed down all of a sudden and being told, you're no longer going to be my patient, you're turning 65. So it's something to consider, and it's something that, as I say, we have a lot of adult members in our charity, definitely, willing, say, we're members of the Rare Disease Partnership here in Northern Ireland, or up in Northern Ireland, so something where we'd be willing to talk to any of you about. Thank you.
Thank you very much.
Can I make a comment?
Yeah, Alison, if you want to, and Dara, there's a question up at the very front. But
So,
Alison, if Alison wants to respond.
I'll be really brief. So there's a development. I mean, I guess the thing about rare diseases are that very often a patient gets looked after from a paediatric age group all the way through to adulthood. And so rare disease services balloon, and we can't follow everyone in the same way forever because we are restricted by capacity. And so it's trying to come up with innovative ways to stay in touch with our populations. And I think there's something that we're looking at now where patients don't necessarily need us all the time if they've got a diagnosis and an established management plan and established who their consultant is or who their team is. So we're looking at this new strategy for modernising outpatient follow-up with a thing called PIFU. So it's patient-initiated follow-up. Mm-hmm. So you can remain someone's patient, but you don't need to keep coming back to the clinic. But you have someone that you can call if you get into problems. Because actually, sometimes people just need to know, I have someone that I can contact if I have an issue, but they may never have that issue. And for a lot of the inherited heart diseases, that is what we will do going forward. We will try to say, look, you are a patient, but you don't need to come to us, but you call me if you have a problem.
Yeah, slightly different approach.
The GP is often the person who's more involved, and as you say, clinicians are as involved. But I think it's an important thing to prepare and that people are more aware of it, and that little, piece of paper or an email or a text, being given the name of the contact in advance, and maybe even a very brief meeting, the handover from one physio, social worker or whatever to the other.
Okay. Do you want to, Bruno, I think it is, yeah?
Yeah, it was just, I think I disagree with everybody, but basically I do not agree with the community approach. The expertise is in the hospital. I went to speech and language in the hospital because you have to go to them first of all, and then they send you to the community. They had other patients with my condition, so they were able to tell me stuff. I've gone to 5 different speech and language therapists in the community. None of them have met anyone with my condition. I've also had issues when it comes to physio. In the community, you have physiotherapists. You have no neurological physiotherapists. They are in the hospital. You need to be in the hospital. I also have the issue that when you are sent out to the community for, say, what's the word? Yes, psychology or whatever. The issue is a lot of neurological conditions are genetic, so family members both have them. You can't be with the same psychologist. So I have no psychologist because my sister has one. So what do you do in that case when the hospital won't take you on their system, but yet they're sending you to the community, and the community won't take you on theirs?
Yeah, I think it's not the very example of, it's the individuals. It'll have to be accommodate every individual's needs. There is no one size fits all for this. We'll try and, I guess, get systems that'll work for lots of people, but we have to recognise there are still individuals. David, you want to add something there?
Just make a comment on that, and thank you very much for sharing, because we can't get enough of those stories back about the feedback, about the lived experience, but just try and give some, I'm going to try and give a little bit of comfort with what I'm about to say, and I hope it does come across correctly. We can be criticised the health service over many, many things, but there's a fundamental restructure of health service. No, I'm agreeing with you. So,
but I'm not criticising.
No, I know you're.
In the sense that the expertise is in the hospital. They just won't keep me in the hospital system to get it.
No,
it's there.
I agree with that. I was going down a slightly different route about the restructure in healthcare. And one of the plans is actually bring some of the expertise out of the hospitals and into the community. It's the flip way around. So yes, it's to try and bring that expertise closer to people in the community that need it. Mm-hmm. So it's not the community facility it's the expertise isn't sitting in that building. So what we would try and do through some of these pathways is that to deliver that by the right expert. So somebody who has seen patient with your condition or with other, or like that neurological physiotherapy, but try and deliver it out. Or am I missing the point there? Or there's a comfort in the centre.
I'm trying to get across that we're rare conditions, so you're not going to have enough people with the expertise knowing other people with this condition in every community.
No, I appreciate what I'm saying is we move the experts out of the hospital. So if we've got an expert in Beaumont in neuro physiotherapy, but actually one day a week they're in Cavan or Monaghan delivering neurophysiotherapy to a community in there that needs it. So the patients that require that specialist care don't have to get on a bus from Cavan or Monaghan down to Beaumont. We bring the resource from Beaumont out to Cavan. That's what I'm trying to get to. But I do realise over the years the frustration is talking strategy is much easier than delivering on the strategy. So I I've fully put that qualifier in. I've had my own fingers burned for things, but it's
okay.
important to have that feedback back.
Yeah. Thank you very much, Brona, for sharing, and David. And I'm going to, in the interest of time, because I'm now my religious half hour behind, but I'm going to blame that on somebody else. Raquel, thank you very much for taking the time to zoom in with us. Really, I think there's a lot of insight, and I think we'll be back to you with lots of questions and things like that over the coming weeks, particularly as we're embarking on writing up strategies and implementation plans. And thank you very much to my panelists. I know I browbeat you, and next year you'll be dancing up here saying, "Yay!" I know what to expect, but I really do appreciate it. I know it's not easy, and sometimes it's a little bit daunting to be up here, particularly with me, who just keeps going and going and going. But there's more tea and coffee outside. We're going to cut this break super short because I really do want to make sure that we have a good chat with Emer Cook from the European Medicines Agency. Right, thank you very much, guys. Hello, hello. The happiest bunny in the room is up at the podium now. We have made it 3/4 of the way, and I'm certain that we have saved the best to last. If for no other reason than my favourite colleague in the Irish patient community, Derek, who's paying no attention to me and doesn't realise what I've just said, is chairing this next session. Derek will be familiar to many of you. I guess I would have to say what I would say about Derek is patient front and centre. He is constantly, where are they? Have we learned? Have we listened? Have we brought? Are we really doing what they're asking us to do? Are we really delivering? And it's great always to have him there. And I know he wears many hats across many different, aspects of the healthcare system. But he is always the person that's saying, where's the patient? Who brought the patient in? How did this happen? Who are they? Are they being supported and things? And I'd have to say he's a great advocate for all of us. Whether or not we are living with a rare disease or a family member or just the rest of society, making sure that we're being listened to just as future patients as well. So Derek, Chief Executive of IPOSI and all the rest of it, thank you very much.
Thanks, Vicky, I think. I'm reminded of my aunt saying when she was asked, why do you like Derek? And she said, well, because he's short and sweet. So, and I hope that's probably an emblem for this particular panel, because we probably have to be short and sweet about it. So the whole purpose of this final panel is about advanced therapies for rare diseases. And thank you for staying with us. We're joined by a number of panelists, and in particular, Emer from the European Medicines Agency. And really, the whole area of advanced therapies in Ireland, when I started in IPOSI 9 years ago, the idea that Ireland could become a centre whereby new cell and gene therapies that were starting to come through at that time, that Ireland could actually develop a plan whereby these could be ultimately adopted into clinical service, into that clinical trials would become more available, but fundamentally that we would see it as an Irish strength and an asset, was probably pie in the sky, if I'm being honest, at that time. Whereas now, when you look at it and you actually appreciate just how many advanced therapeutic medicinal product trials that are actually happening in Ireland, and we'll hear about them from some of them from Martina. And when you look at the trajectory of where things are going now, that this is really happening now, and it really does need a national approach to how we make this much more relevant to an Irish context. So we're going to hear from Emer in terms of that European regulatory framework that's already in place and is producing results. And we're going to hear from Martina from St. James's campus that has already been conducting trials, and we'll hear about what the experience of that has been like. And I think Anne-Marie is still here with us, is she? Somewhere. Yes, down the back. So we'll hear from Anne-Marie in terms of, again, looking at this whole new technology, new area from a patient perspective in terms of how that patient voice can impact and influence the direction of travel by which these products are both produced, developed, assessed, and commercialized. So we'll then open it up for questions from the floor, but I will just keep it short and sweet, and I'll invite Emer to come up and to give us her perspective from the EMA. So Emer, you're most welcome, and look forward to your talk.
Thank you very much, Derek, and thanks very much to Vicky for inviting me today. I have to say, I always find experiences like this very humbling, because I'm I'm very Irish, but I haven't worked in Ireland for an awful long time, and I know very little really about the Irish ecosystem. So when I see the things that we do are really having an impact on how Ireland is bringing stuff together, I always feel very, very proud. Yeah, it's a real honour for me to be here today, and I want to thank Rare Disease Ireland for inviting me. Just to tell you a little bit about my journey with rare diseases, I have been working effectively in European regulatory affairs for some 30 years now. And in 1998, I went to work for the European Commission as a policy officer. And one of the jobs they gave me was take this orphan medicine regulation and make it into a regulation. And I said, well, I don't know anything about legislation. Actually, I'm a pharmacist. But I have to say I did. And the orphan medicines regulation that was adopted in 2000 is the result of a lot of running around and finding out things that I did back when I was a lot younger than I am now. And it was a very, very rewarding experience because it brought me into contact with patients, with developers who were struggling to get their voices heard, patients who were struggling to get their voices heard, patients who had no treatments, no options. And it really made me think, you know, how do we change? How do we make change happen in this area? So I did a lot of talking to the US, to different advocates at the time, learned a huge amount about the challenges. In the meantime, I realized that my father and two of my grandmothers were well, I don't know, the 3 and 17 or the number 17, but, you know, everybody is, if you look into it, you're closer than you think to somebody with a rare disease. So that was the start of my journey with the rare disease community, and now 25 years on, I haven't spent all my time working on rare diseases, but I'm in a position now as Executive Director of the European Medicines Agency where we do have a responsibility and an ambition to really make a difference here, and this is something that is very, very close to my heart. So we want to do what we can to advance the possibilities for patients having access to better medicines, and I think the whole area of advanced therapy medicinal products is an area where really there is a huge difference. So in the EU, there are more than 6,000 distinct rare diseases, which affect around 26 million people. And I have to say, in those 25 years, I've seen huge advances in medicines and technology, and I really feel we're at the cusp of something special now with the technologies, the connectivity, you know, whereas when I started this, you know, you were trying to find out something about a disease. You're trying to find something about the incidence of a disease and you didn't even know where to start. You didn't even know where to find the experts involved. So now with the access to so much more data, the real challenge is how we bring it all together and make it work for us. And I think that's something we're trying to do in a lot of different ways, but it's core to what we have to do going forward. So I do feel it's a time of huge potential and that some of the promises will really move into realities. So I wanted to talk a little bit, before I talk about ATMPs specifically, I want to talk about the role that patients play in the work of the EMA, and then give you an insight into some of the specific initiatives and programs that we have to support the development of medicines for rare diseases. And then I'll talk a little bit about some of the ATMPs in the pipeline. And then I think I couldn't finish without talking about collaboration and partnership. And this is something that you've heard about today. And just in the last session, you know, the challenges they're never the challenges are more about bringing everybody together than what you can do in your own area. I always say, I know what I can do in my area, but that's all. But to make something happen, I need to know what I can do in multiple other areas for which I am not responsible. And I think we need to, work on that together. But one of the most important the most important voice in our regulatory work is the voice of the patient. And we play a leading role in the facilitation and development and authorization of orphan medicines. But we need to know the real story from the people living or caring for people with these diseases, because I think we've heard nobody can be an expert in every single one of the rare diseases, but every patient is an expert, every carer is an expert, and we need to know how to bring that voice into the work of the regulatory system. We have been engaging with patients since we started in 1995, and in the beginning it was effectively informal discussion groups. But the orphan regulation changed the game because it brought in patients as members of our scientific committees. And this is one of the things, and I don't take any responsibility other than I pushed it through the statute books. It wasn't my idea, but it was a game changer in terms of involvement of patients in medicines regulation. And every single scientific committee created since the Orphan Medicines Committee has had patient involvement, and you will see that continue going on. So our interactions with patients has become a lot more formalized, and I think patients have learned and we've learned how to make the best, how we make the best of that expertise, and we use the expertise, the patient expertise, to contribute to the overall scientific knowledge. Eurodis, the EU Organization for Rare Diseases, which was actually the Jan LeCam was our first committee member on the Orphan Committee back in 2000. And I think today is his last day in the post. And Eurodis is turning 18? 18? No. 20, it can't be. See, they don't give me the right notes here. So I do think that, when we're looking at any medicine, but again, particularly medicines for rare diseases, we have to really understand the benefits and the risks and what matters. And sometimes we're guilty of being too academic about the benefits and risks. And when you ask a patient what matters to them, that's what matters to them. And it's not the hypothetical risks that we talk about. They might be prepared to take the risks, and we need to understand that. And it's truly great to see how patient groups are much more informed and knowledgeable, that they have influence, more tools to use, and it makes a huge difference to our work. It really helps to make it real. So I just want to say how important that is, and how important it is that you use your voice to make sure that the impact is meaningful. We involve patients in our risk assessments. We also use patient experience data to improve outcomes. You all know about the living with the disease and the treatments. And it's been a learning for us also, because I do remember the reticent with having involvement of patients in the regulatory work, because the scientists thought that it would be driven by emotion rather than science. And we had to get the balance right and really make sure that actually, yes, we're patients, people living with rare diseases, know more about these diseases than everybody else, and their voice needs to be heard. Now, I spoke a little bit about the patient experience data. Today, actually, we're doing a workshop with the EORTC looking specifically at patient-reported outcomes. It's in the cancer area, but we have a full-day workshop on patient-reported outcomes, and it's becoming much more part of the formal regulatory system. The other thing I wanted to talk a little bit about is about the clinical trial system. We're trying to do work on improving the European ecosystem for clinical trials, making it less administrative, less bureaucratic, and trying to use the power of Europe to get more data and benefit. And we have an initiative which we call ACT-EU, Accelerating Clinical Trials in the EU, which has a number of different work streams. But one of them, I think, which is very important in the rare disease area is the use of decentralized clinical trials. And I'm always very struck by, thinking, when I think of how difficult it is for any patient to get access to clinical trials. And then you think of how difficult it is if you're a patient with a rare disease to have access to clinical trials. And it may be going on in Greece, or it may be going on in the US. So, but if you can try and use, you can try and systematize decentralized clinical trials, you can give greater access to patients. So we can use digital tools, we can use telemedicine, more mobile and local healthcare to collect information. And there are huge opportunities here that, again, we need to really build on and hear also the voice of the patient here to see what works and what doesn't work. The other area I wanted to touch on briefly was the whole area of real-world evidence. We have been investing heavily in getting feedback from real-world data sources. We've put in place a network of different data sources, the Darwin Data Analytics and Real-World Interrogation network, where we have data sources from some 30 different healthcare data sources. And we try and bring this together to give us better information about how treatments actually work in practice. But one of the challenges we have, and I was talking to somebody about this during the break, was that we need to have a common data model, because if you're looking at different healthcare data sets, and you want to use them effectively, you need to have common standards and be able to integrate them. And that's where the data that comes from a small country like Ireland, you want that data to be able to be used in a more international setting. So you have to also think about the data standards. So we use our real-world data sets to understand more about patient characteristics, treatment patterns. We can use it for epidemiology as well, but we're also working with the health technology assessment bodies really to look at, okay, so these products have been authorized. Most of the rare disease medicines will have been authorized on very little data. Now, how do they actually perform when you get into real life? And that's a very important question. It's an important question for the patients. It's an important question for the healthcare systems. Now, we can improve our chances of treating rare diseases by increasing the number of ATMPs with orphan designation. And between March 2023 and March 2025, we're expecting some 39 ATMP submissions. And the percentage of ATMP orphan designations went up last year to around 10%, from 10% to around 20%. So we're expecting and preparing to have a lot more applications in this area. So earlier this month, we recommended granting a marketing authorization for Quysody, which is a treatment for ALS, and As you know, and I know we have, I think he might be gone now, but Jonathan from the SMA Association, I mean, a couple of years ago we didn't have any treatments. Now we've got 3. So, and once you get a successful treatment, the chances of getting another successful treatment are much, much higher. But there are lots of challenges, not just because of the small data sets, and also because sometimes the applicants for ATMP trials and medicines have less experience with the regulatory system. So we're trying to also make sure that we provide the right information, that we do provide, that we anticipate the hurdles rather than to wait until the end of the system to say, oh well, you didn't do it right, because that's no good. That's no good for anybody. We have actually a pilot scheme that we're doing at the moment with non-commercial developers, where they benefit from enhanced support from us at the agency. The first participant that we selected for this pilot scheme was the Hospital Clinic of Barcelona, which was producing a CAR T-cell product for the treatment of patients with relapsed refractory acute lymphoblastic leukemia. And the second round of the pilot, which we finished in December, had a total of 11 candidates, and we were able to select 2 of these, and both of them were developing gene therapy products. And these are being developed by non-commercial sponsors, and we commit to doing effectively hand-holding to help them get through the system. So these are some of the ways that we're trying to address some of the complexities of the pathway from development to patients. We have an innovation task force which provides a forum for discussion on all aspects of medicine's development, on the scientific side, on the regulatory side, on the legal side. We have an office for small and medium-sized enterprises, which help, one of their jobs is to help to support academic startups and smaller companies that often perform the initial research on rare conditions. So we really have multiple systems in place to try and help to structure a program that will then meet the regulatory requirements further down the line. And as I speak, we're actually hosting a webinar, 1,000 people online at the moment, to celebrate Rare Diseases Day. It's an interactive webinar answering questions that developers and researchers have in the field about orphan designations, about rare disease developments, and we're encouraging everybody to participate, ask questions, interact with our experts. Now, obviously, you're listening to me and not this, but the video and the presentations will be available online after the event. So that's just a small snapshot of the work that we're doing, and it's only a small part of the journey of a development of a product that actually comes to a patient. But it gives you, I hope it gives you an idea of how we're approaching the challenges of rare disease and unmet patient needs in Europe. And we know the challenges. We know we have to do better. We know we have to be closer to the real challenges of patients, the challenges of developers. But because we know that if you're trying to find new treatments for rare diseases, you can't work on your own, and it's important that you collaborate closely with partners and stakeholders and patients. Also at the international level, we do a lot of work with the US FDA, and we've started a specific collaborative pilot now on developments for ultra rare diseases, where we're trying to share between the US. I think we're also involving Switzerland and Australia to again see how much we can do together, because we're all faced with the same challenge. If it's a rare disease, you have less data and you want more. I heard a lot today about the European reference networks, and I'm very proud that Ireland is so involved and active in this area, because these really do facilitate the discussions on complex or rare diseases, especially ones that require highly specialized treatment and concentrated knowledge and resources. So this just brings me to my final point on collaboration, and I think you've heard about this a lot during the day. We have our part to play as the European Medicines Agency. Patients you have your part to play as well. Developers have the part to play. But to be successful, we have to work together. And I find it really, really heartening to see that Ireland's strategy for rare diseases is taking shape. And I see that it has patients at the centre, and I think this is a very fundamental approach going forward. So if we're going to make progress in this area, and I truly believe that now is the time, then we have to do it across the multiple different ecosystems that we all live in ourselves, not just in our own. I know what I can do, but can you imagine how much we can do if we can all do this together? Thank you very much.
Thank you, Emer. If you'd like to join me and Martina and Marie, if you'd like to come up. So again, thank you, Emer. Thank you for highlighting, first and foremost, the role that patients have played in EMA, and not just in terms of the scientific committees, but in terms of how it has evolved, I think, and the role that EMA plays now in that innovation ecosystem as a key partner. I think, to use the phrase used earlier, the question is now, how do we make that leap across those different ecosystems, with the patients very much at the center of it? And how do we then bring your experience? I'm also conscious that I probably have to ask you some tough questions, but if I think about when I read your profile, and it's like, so Emer was appointed in November 2020, and I think about maybe your first 100 days in that job, there's probably no question that I can ask that you haven't heard already, but or that you aren't capable of dealing with. But before I come to maybe the tougher questions, I'll ask maybe Martina.
Lucky me.
So from what you've heard, from what Emer has outlined in terms of that regulatory environment, and maybe over the last few years of your experience of working with clinical trials in St. James's, and in particular the CAR-T cells and these new technologies, and the infrastructure that may or may not be there, how can you tell us what the reality is here?
Well, I think a lot of what Emer says is absolutely spot on, and you can definitely see the shift in European thinking to do all the things that you describe. Where I think the biggest challenge on the Irish side is the data. So you cannot be part of something if you cannot contribute to the data in a meaningful way. And we're really stuck here with our e-health strategy. I'm glad it's been published, but it has to be able to conform to the necessary sort of parameters to be useful in a research setting, and to be contributable in a research setting. And we seem to be, perhaps we haven't expressed a big enough ambition for that, and for the levels of governance that need to come around that, and the data rules. And on that's on one side. And on the other side, we seem to be continually falling over ourselves with concerns, sometimes valid and sometimes not so valid, about GDPR, which is inhibiting us putting forward data. And maybe making people feel overly insecure about where that data is going. So I particularly was glad to hear Emer say that the patient's tolerance for risk when they have a very significant burden of disease is quite different, and it's very important to inform that patients inform, their risk appetite for any given study. I know that was a very well-made point. The reality on the ground is that a decade ago, just as you say, we would have been sending people off to have, they would have been trying to find their own way, first of all, to the States perhaps, to get themselves into a trial, and they might have been spending 3 or 4 months there or longer with their family, trying to figure out how to continue their life while they were accepting rare treatments. And being part of clinical trials. And we did that all the way up till a few years ago, but I don't really believe that's necessary anymore. So for all, I mean, I would say I'm treating quite a number of rare diseases, maybe 14 or 15 at this stage. I'm not an expert in any of them, right? But I'm an expert in the complexity of delivering the advanced therapies and delivering the clinical trials. And there's some commonality in that complexity which we can build on and build an experience on that ensures that what's delivered to the patient at the end of the day is meticulously excellent. And that's the balance that this lady pointed out between trying to commit to personalisation, committing to excellence is really what you're talking about, committing to excellence, but at the same time understanding how to achieve a level of integration so that it's manageable, you know. So I think that's the job for me, for Cecily in her strategy, is finding and wending that balance so that patients can get the best experience they can, including access to research.
Thank you. And can I probe you a little more, but just about the experience of running the CAR-T trials in the unit and what that experience has been like?
It's been excellent. I mean, it was a very slow gestation because there's an awful lot of work to do to determine that all of the resources are in place in that healthcare setting, in this case St. James's, to perform the trial. And then there needs to be, you know, the inclusions and the eligibility will be very tight. So a lot of patients will not meet the inclusion criteria for one reason or another. It might be nothing to do with them. It might be simply age. It might be something else. You know, so there's a lot of hard work, and it takes 6, maybe 9 months before you can get into position to make a start to that kind of work. And then you have to travel, well, the patient travels a journey with you, so it's a real parity of esteem relationship when a patient comes into a trial, because they decide every single day that they come in, if they're going to come in the next day, and therefore are they going to continue in the trial. So the word that I would have put at the end of your you know, your informatics pieces there would be in charge. So that's the one thing I would add to that. So when you come into the clinical trial arena, to a great extent, the patient is in charge of what happens next because they agree to continue every day. So we will have walked maybe an 8 or 9 month journey a second time with that patient while they undergo standard of care, because of course we must at the very minimum provide the best that we have available at a given time, and then before one can be randomized to go to the next step, perhaps into you know, new drug X or orphan drug X, and then we follow that journey all the way through, sometimes for as long as 15 years, you know. So it can be a very long time to have bad data. It can be a very great time to have great data if you can contribute it. So, and there's many times at which you might fall out or perhaps have to leave the trial during that, but hopefully you go to the end and you're very invested then, of course, in what happens, and to see it come around to its health technology assessment if it's a successful drug. But I couldn't overestimate the value of having Irish patients make their contribution to worldwide evidence. That is really significant, because then we have a much greater handle on how drugs will behave in an Irish population, what would it take for us to be able to deliver those drugs successfully to Irish patients. And when Irish patients make their contribution all the way along, that journey becomes an awful lot easier.
Thank you, Martina. That's great, and I will probably come back to you on a number of points, but you've actually segued quite nicely to Anne-Marie. And I guess from what, Anne-Marie, you've heard in terms of, Emer's described the patient experience data being increasingly part of the formal regulatory process. So the question then becomes, well, where is that data going to come from? I mean, Martina has described a kind of an ideal scenario where it comes from patients. But what can patient groups be doing to maybe ascertain, well, what are the outcomes maybe that are most relevant to your group, and how you might go about even collecting or even being the custodian of data that can help approval and ultimately availability of therapies.
Yeah, so I suppose my experience is of the Community Advisory Board. So I suppose that's the key for us in the organisation that I have been involved with. So yeah, so I mean it was really good to hear about the patient input in the EMA, and that's really important. And I suppose as I was hearing what Emer was saying, I was thinking, how does that trickle down to the HTA and to Ireland? And I suppose there's a sense of we're not really sure, I suppose. So it's fantastic, and that's what we want to hear about, what's happening in the EMA. But we're still struggling with that other piece. So I suppose from my experience, so I suppose I represent a charity called Cystinosis Ireland. I represent a couple of different organisations now, but the key one was Cystinosis Ireland, and what we got involved with a number of years ago was creating a community advisory board. And this is an international group of patient organisation leaders and members who have come together now in a formalised way to engage with industry for clinical trials and to engage with researchers, early stage researchers, universities, around research in general. And we were originally mentored by Eurordis. We actually got the idea from a Eurordis meeting, because we were looking for something at the time that would help us to protect patients actually in clinical trials. We had some negative experiences of patients being taken off treatments, and industry at the time not engaging with us and realising that we were nobody on our own. It's a very rare disease, and so coming together meant that we actually saw a result there and an outcome. So that made us realise we need to come together as a group, and so the Community Advisory Board was set up. For us, I think, the mentorship for Eurordis at the start was really important. We're now autonomous on our own, and I suppose for us to influence what's going on in clinical trials and research is the patient group has to be educated. And we did undertake a lot of education at the time. It was with Eurordis, where every month we met and we learned about clinical trials, HTAs, EMA, FDA, pipeline, all of that. And the group met every month, studied in between, and really built up their knowledge, so that it meant that when we came to talk to industry, they could talk with confidence, but also could bring the patient experience and the family experience. And so there was no wool pulled over our eyes when we met with industry to talk about endpoints and all of that. Patient-reported outcomes is an interesting one, and we've struggled with that, in that and it's exactly as Emer said, what's important to the patients isn't always important to the people that we met, or not that it wasn't important, but it didn't seem to matter, because it wasn't going to get it over the line for them to get they felt their market approval, or maybe even more importantly, HTA approval. So that's the thing we're still struggling with, actually, and patient-reported outcomes and what is really important to the patients. Quality of life is like, for all of us, is the key. And a patient doesn't want to be on a treatment that doesn't work. That goes without saying, So, they want it to work, they want the quality of life. In relation to the CAB as well, the CAB is autonomous. It has, and it's independent. It sets the agenda for these meetings with industry when we meet with them. So I suppose, if I'm answering your question, an educated patient group, equal partners in the discussion, and what the patient group brings is seen as valuable and is used, and how it's used afterwards, and the transparency and of where it's used, and a lot of work is put into that, and the patient group would need to see the outcome and where their work has been influential. Yeah.
Thank you, Anne-Marie. And if I can even follow that up, and I know that that you've been involved with the technology review group for orphan medicinal products in Ireland for a number of years, and without divulging any or crossing any confidentiality issues, what has that experience been like? If you're able to tell us, as a patient advocate.
Yeah, myself and Avril were both the patient advocates on that. It's been a really interesting experience, actually. I suppose the first thing you'd need to say is that if you're going in there, you need to be able to stand your ground with the rest of them as well. You know, you need, again, the education is important, going in as a patient representative. I suppose what I would say, and this is more personal than anything else, what I saw as influential is the patient voice in there. And it sounds almost cliche to be saying that, I think. But what we did notice that if there was a treatment for a really rare disease that didn't have an organised patient organisation, it was much more difficult to get the information. You're kind of trying to get maybe one person, and I know, you know, the group did try very hard to get that piece. So if you haven't got an organised patient group organisation, it's probably a bit more difficult. And of course now you can go internationally as well, but it's like what you said, Martina, you know, the Irish authorities want to hear the Irish experience. The clinician input was really important too, because if you don't have a patient organisation, actually you'll have a clinician somewhere that's looking after that patient, and they do become expert and knowledgeable, even if it isn't their first specialty. And I think and they are good advocates for the patients. That would be the other thing I would say. You know, I think in preparing for this, Vicky had said one of the questions I'll be asked is the barriers to access. And I suppose, I have to say it, even though we're not supposed to talk about money, but it's the barrier. It's the number one barrier. It's the elephant in the room. And as a patient organisation and as patients, you know, we're at the mercy of the industry on one side who, you know, is setting the price of the treatments. And at the mercy of the health authorities on the other side who don't want to pay. And at the end of the day, you know, we're caught in the middle. And that's something that needs to be addressed. And I suppose the only one point I'd make was great to hear the Minister saying there was 30 million for new treatments down the track. But, you know, the government gave 95 million to the greyhound industry last month. So, you know, Avril and somebody else talked about how you judge a society and how you look after your vulnerable people. So, you know, we have to think about that too. And it is the biggest barrier at the moment, isn't it? Yeah.
It's a great point, and I'm glad you made it, because certainly I think in my experience of working with maybe the health economists of the world, that certainly when health economists ask society and ask patients and the public, you know, you do our job for us. You weigh up these kind of things, and you tell us which you prefer. Would you prefer to invest X amount in X treatment that will treat, you know, thousands of people, or this very specialized treatment that comes with a price tag for this very small population? And they're consistently surprised when the patients and the public come and recognize the value of investing in those that are probably the most underserved by the process. So how you judge that is, I think, where ATMPs are going to fall, really, because they will come with price tags. It's then how do you create an ecosystem that actually recognizes that as not the ultimate barrier for adoption. So, and I'm struck by some of the comments made about the clinical expertise and the education of the healthcare professionals as well. And also the ancillary services around how these new technologies are adopted. Is there any work being done in that whole area, maybe Martina?
Well, there's quite a bit of work around, first of all, values-based healthcare, and looking at how that cost stacks up over life and over the durability of the treatment, and that's been good. And I would say that we've had we had a good start, for example, with drugs like Zolgensma for spinal muscular atrophy, you know, where if it's given early, you can see very dramatic improvements that, you know, you can see how that stacks up well in terms of the value then of not having to provide excessive levels of healthcare or very high levels of healthcare, complicated healthcare for a child who's treated. You can see similarly good stories in the haemophilia story, you know, because, you know, factor is so expensive in itself that anything that adds significant benefit and reduces the need for additional drugs and improves the patient's quality of life, it's hard not to be impressed, you know, by that. But then there is as well a need to think about, we shouldn't be thinking about every new advanced therapy as if it was a new event, you know. We have to come to the point of being able to think about what we need by way of fixed costs, you know, to support that infrastructure, and then additional costs depending on the nature of the disease, how rare it is, how complicated the drug is, and so on. So because when you have the fixed infrastructure, the cost per patient each time is reduced. It's better. So you have to see it in that sort of way. So, and there's a whole piece of work being done by people in this room around Ireland's readiness for advanced therapies, and not just its readiness in the clinical scenarios and in the clinical trials, but also our readiness in terms of adoption, in terms of delivery, in terms of pricing, in terms of dispensing, in terms of follow-up. So there's a whole big piece of work to be done around that. But we always say that Ireland can be the home of the pilot, the porta-cabin, and the interim solution. So this, I would say, is an area where maybe the short-term solution is not going to be helpful. We need to think very long-term. We need to be looking ahead 10, 15, 20 years into what we need. So, for example, there are 6 clinical research facilities in the country, but none of them are funded as core funding. They're all funded by grants. And there's many research programs, and there's research programs coming in cellular treatments, but they are all funded as programmatic grants. So we need to get to the point where there is a recognition that this is going to be part of our future, and we really need to start getting ready for it. Sure, I think you would agree with that, would you? Hopefully you would.
So you're making my job very easy here when you mention readiness, because I can pivot. So, Emer, from what you've heard, both today, I think, but also from our panelists, on that readiness piece, have you seen other countries who have gotten much more ready, much more quickly when it comes to ATMPs? I was struck by a report that came out from the UK recently. I think that they did invested heavily in their readiness, whereas in Ireland it seems to be less. Well, certainly what I've seen so far has been more on the manufacturing capability side, rather than maybe the readiness of the system to adopt this in terms of both. I guess that's juxtaposed research and clinical care together. And that's what I think you've just described. So have you seen any examples from other countries coming through?
Well, to be honest, I'm not really, I don't know exactly how it happens in other countries either, so I can't really tell you. You do see some good examples, but they're usually just examples. I think the idea of having, I mean, we're seeing now a lot of strategies for rare diseases. I think there were 23 or something across Europe. So people are thinking about it. I mean, when I started, this didn't happen. This didn't happen, and it's not going to happen overnight. If you think about all the challenges that you have. And yes, maybe Ireland has more of a focus on promoting manufacture, but what we just heard from Martina now in terms of clinical trials, that's pretty impressive, isn't it?
Certainly.
So I would say I don't think Ireland is an outlier. I think it's well on the track to be a good European performer. Money is always going to be the issue. The resources to make these things happen is always going to be the issue, and it's about choices in healthcare systems as well. So I don't have any insight into. I wouldn't be able to tell you this country is the poster child. I mean, some countries where you have a very interconnected system, it's much easier. But then I'd go to Singapore. Singapore, I think, they get data from their healthcare systems, from their clinical trials. They have, it's a rich country, so there are a lot of things that can happen quite quickly. I think small countries, you can do that, but then you're limited by the data set.
We're back to data. So. I'm conscious as well that there's another event happening today on clinical trials for rare diseases. It's up in Malahide, And it's going on tomorrow, so for anyone who wishes to continue this conversation, it might be well worth getting up to Malahide. But there are those, I hate using this word, but pockets of expertise emerging in Ireland around this. And many of them are in the room, so if anybody wishes to raise a hand and ask a question, I'd be happy to receive those. There's a mic going around. I know there's two hands there, one from Alan, and I think there was maybe, yeah.
I have a question for Emer, but I'll give the context first. For me, rare diseases are split into 4 categories. You have common rare, medium rare, rare, and ultra rare. And for the rare and ultra rare, for me, funding for research has been waning for a number of years, and certainly investment by companies has been waning for a number of years. And to try and reinvigorate that, my one wish to the EMA would be to try and create a priority review voucher like what the FDA have. And I think it would be a complete game changer in terms of investment for therapy development and even basic research if there's good proof of concept in rare and ultra rare diseases. So I just wonder if you have any comments on the possibilities. I'm sure you've thought of this before. Thank you.
Thanks, Alan. I think that was a direct question to Emer, but...
Well, it was a direct question to me, but just to be absolutely clear, it would not, it's not something that EMA can do. This would have to get on the legislative books, and then we would be able to apply it. But that's a question for the legislator. And I wouldn't be too hopeful at the moment, because we have at the moment there is a voucher at the moment on the statute books for AMR, which is getting a lot of challenging response. So if that was to be successful, I would say there might be a chance in the future in the rare disease area. But if I was being a careful advocate, I wouldn't put it in on the table right at the moment.
Question from Avril.
Thank you. Thank you. I also have another question for Emer. Sorry. But you mentioned something in your talk, I think that was really interesting and maybe interesting to many of the patients in the room, about a new, I think, a pilot discussion between yourselves at the EMA and the FDA. In the context of your question, Derek, around data, a lot of patient organizations now are preparing for the advent of therapies. They're listening to you and others who are decision makers, essentially, about what type of data should we be gathering, particularly in the context of patient-reported outcome measures, you know, etc. So in your discussions with the FDA, is there are diversities of approach, let's just say, in how we accept these particular PROMs and other endpoints, but sticking with PROMs for the moment, is it possible to have those discussions so that we can arrive at some form of uniformity? Because all of us here, we're talking about this in the Irish context, but our research is not only European, but it's global. And so this is something that we as patients are concerned with right now. So just wondering if that's something that's on your agenda.
Yeah, I mean, I've been working on international collaboration pretty much my entire regulatory life, and honestly, I am absolutely passionate about us trying to make life simpler internationally. But I will also say it's not as easy as you think it would be, because there are different contexts that once you dig and you see, you try to understand why things are done differently. You also see that there are different healthcare contexts that make a difference. There are different standards of care that make a difference. But the good thing is these things are discussed, and they're tried to, you have our experts are trying to say, okay, well, what is the best way? Not just what is the way we do it, but if we look at it from a global setting, what's the best way? How can we serve patients best? How can we get the best medicines for patients? So these discussions do go on. They go on very much at an expert level, but they're complex.
Struck by Martina's point about the commonality of complexity, and if that's a quote I can use. David, yeah.
Yeah, just a quick, thanks for that, Emer. And just a quick one, I was conscious I spoke earlier on, but just really, you're drawing it out there, the experience in the room. Martina's touched on it. It's so difficult to get these things up off the ground in Ireland. All it is a trying for perseverance. And somebody, Minister alluded to this earlier on, someone who perseveres is an irritant as well, so you create a lot of enemies along the way, but we're doing it for patients. But when you hit other things that are very frustrating, so I don't really need a comment, but I think Martina's lived this, and Marie sort of has watched it, and Emer's well aware, and you're aware, Derek. To be close to setting something up and waiting for the approval to come through, and you touched on this about funding being a barrier, and I would have said that until last year, when 3 or 4 patients who would have been suitable for a gene therapy treatment for an eye disease are signed off for the treatment abroad scheme while we wait for the approvals to come through in our country, is a real kick in the gut to all those who work really hard to try and get it over the line. So it's just sort of a statement of frustration. If anybody's sort of aware of that into the room, we're ploughing on regardless. And Bettina's been so helpful in us setting that up and really highlighting that point about that collaboration, because we're a small island. But really to say that there are multiple barriers along the way, but not all of them are financial. And I fail to understand why some decisions like that would be made. To be honest, to avoid a row, I didn't write any letters or anything through. The children were looked after, main thing. They're doing really well, and they'll come back in under our care, and we've looked to put them onto the post-licensing treatment here. But we're losing that information, that experience for Irish patients. We would have the expertise now of treating 6 eyes in 3 patients, rather than starting now as we are in 6 weeks or 8 weeks' time with our first patient. All these are missed opportunities.
I would say I very much agree with you. And we really need a mandate to collaborate. We need to be told it's okay to collaborate, and that in that collaboration it's okay to break down mad barriers that are in the way, including some mad geographical barriers that are in the way. So for example, can a patient who's always been looked after in the Mater be looked after in St. James's, or vice versa? Can a patient from the north come down to the south to access something, so that they can get a greater level of expertise and experience, perhaps, and one of our patients go to the north? That happens in practice, but often, unfortunately, it's not necessarily it's not as overt as it should be. The accessibility mechanisms.
Very interesting in the current political environment in terms of All-Ireland collaboration and maybe the appetite for that.
Well, it certainly should be. I mean, it should be the case.
Easier for us to collaborate sometimes with Belfast than with
Okay, so I don't see any other hands in the air, but I do see Vicky at the back of the room going, thank goodness we've got to 5 o'clock, and we're thereabouts. So, like I said, there's more to be said on this topic, but there are green shoots of opportunity. So, in keeping with that, I would just like to thank all of the panelists, and I'll hand over to Vicky for the final words.
In the interest of timeliness, I'm going to suggest that you just hold your seats, because there will literally just be a minute or two. I do want to thank everybody for coming along. This is the start. Well, this is the future is brighter, but it is really the start. We've all heard a lot today, and I think in particular what I'm hearing here is we need the systems in place for 10 years' time. I'm like, Emer, you said, what, 30 products? I mean, hello. I can just see what's going to happen when that, when those approvals start to come through, and we will be back to square one. I can guarantee it, unless we start to think, we really need to think really quickly as to how we do this, how we're going to collaborate, amongst the Irish, how are we going to collaborate internationally. The comment there around, I think, your geographics, and, that is a huge concern with Sláinte Care, that we're putting patients into, or people into different regions, and they're going to live in their region and their healthcare is all going to be provided there. We know it's not practical. We know it's not going to happen. I'm certain that somebody in the Sláinte Care area knows that it's not practical, but I'm still not sure that they've come up with any solutions. And I know that there are patients today that are living in one part of Dublin, seeing a consultant in one part, that aren't getting access to the expert, to the genetic test, or to the therapy, because their consultant is just not saying, let's just pass you over there, actually, you should be. And as patients, we must be demanding that we are with, that our information is with, that somebody can come and find me and knock on my door and say, you know what, you should be over here. And it's not because I want a hold of you, it's because there's this particular thing happening over here that you should be aware of. We keep on talking about consent and things like that. I really do fundamentally believe that everybody who is in the healthcare system, that has needs of the healthcare system, should be revisited every couple of years and kind of say, all of these opportunities are here. Do you want to change? Do you want to think differently about what you're doing, rather than you decided 10 years ago to opt out and that's the end of it? We're all changing, we're all evolving, life moves on for all of us, and we've got to make sure that these are regular conversations that are happening, and that there are regular opportunities being presented. There will be the whole session has been videoed, the whole day has been videoed, so we can all revisit this. We can think about what has happened and what's been said. There will be a report coming out, and the report will be distributed widely. I know Cecily did mention earlier on that it's really timely, and it's great to see so many people in the room. I know that some of our Northern Ireland colleagues have already headed north to try and get out of Dodge before the traffic hits. But, this is an all-island question. There's no doubt about it. We're too small a country, we're too small an island, we don't have the resources, we cannot, invent or build double the infrastructure on the island, and so we need to really think smartly about it. And I know that there's people in this room that will make it happen. I'm not sure if it'll be me, but it will be everybody else, is all I can say. And Emer, we'll have you back again. Don't worry. You're not getting away with it yet. But thank you all very, very much for coming along today. I hope that you have gotten something out of it. I have a very quick Slido, if it is working. Is Slido working, I wonder? Yeah. 4 super simple, super easy questions. What brought you here? Which session which sessions were good, bad, or indifferent? And then what do you think of one word for the rare disease ecosystem today, and what do you think it'll be like in 10 years' time? One word, if you could. What do you think it'll be like in the future? So I'd really appreciate if people could just fill that in and just give us some idea of what's going on. And for anybody that is still online, if there are people still online at this stage, when you come out of the webinar, you will also get access to that. And in fact, I will email a link to this survey as well. But just please, it'd be great to get a feel for, are we optimistic for the future? Or are we all still pulling our hair out? So without further ado, I will close us up. I think we're in or around 5 o'clock, and I said we've done for 5 o'clock. So I'm keeping to schedule. Thank you very much to everybody.